Good morning, everyone. My name is Dr. Anushka Gupta from Muzaffarnagar Medical College, PGJR, Department of Radio Diagnosis. And my topic for today's paper presentation is the role of MRI in evaluation of knee joint trauma. Knee joint trauma is a common clinical problem encountered in emergency and orthopedic practice. Accurate diagnosis is crucial for effective management and optimal recovery. MRI has emerged as a gold standard non-invasive imaging technique for detailed evaluation of soft tissue and bone injuries in the knee due to its superior soft tissue contrast and multiplanar imaging capability. MRI offers a radiation-free modality that helps in diagnosing a wide array of traumatic knee injuries, including ligamentous tears, meniscal injuries, cartilage damage, and bone contusions. The aim of the study is to identify various injuries on MRI in patients of knee joint trauma and describe their MRI findings. And the objective is to describe the bony and soft tissue lesions of knee joint trauma on MRI and the efficacy of MRI in detecting various lesions of knee joint trauma. Sample size was 30, and the inclusion criteria was history of knee trauma, clinical data, and complete imaging. And exclusion criteria was all the patients who do not give their consent for the study, any past history of knee joint operation or any procedure related to knee joint, all universal contraindications of MRI, known cases of any chronic knee joint pathology, and patient having history of claustrophobia. Methodology was proper consent was taken before the procedure in the Department of Radiodiagnosis and Imaging. A brief clinical history of the patient was taken from the patient or by the attendant, and MRI scans were performed in supine position using Siemens 1.5 Tesla MRI machine. So the results were common findings were joint effusion, ligament injuries, meniscal tears, bone contusion and marrow edema, and cartilage damage. So joint effusion is usually detected as the most common finding in traumatic knee injuries, indicative of intra-articular injury and inflammation. And ligament injuries, ACL injuries are predominant, with MRI able to differentiate between partial and complete tears. PCL and collateral ligament injuries are also effectively identified on MRI. Meniscal tears are accurately detected by MRI, which are common in knee trauma and critical for surgical decision making. Bone contusions and marrow edema. So, MRI sensitivity to these changes aids in detecting bone bruises, often associated with ligamentous ruptures. Cartilage damage. MRI identifies cartilage injuries, which may complicate knee trauma and require timely intervention. So this was the case one. Here, in the first image, you can see PDFS hyperintense signals were noted in ACL at its stable attachment site, which were suggestive of sprain or low-grade tear. In the second image, you can see there is on the third image, you can see there is mild extrusion of medial meniscus with irregularity of posterior root, and grade 3 tear was also noted along the posterior horn and body of medial meniscus. Then in the second image, you can see PDFS hyperintense signals were also noted along quadriceps at its patellar insertion site. Mild joint effusion was also noted. This is the second case. Here you can see in the first image, PDFS hyperintense signals were noted in ACL and with near complete disruption of at femoral attachment site, which was suggestive of near complete tear of ACL. In the second image, you can see PDFS hyperintense signal in posterior cruciate ligament near femoral attachment site, suggestive of sprain. In the third image, you can see PDFS hyperintense signal in the medial and lateral patellar retinaculum, suggestive of sprain. Then you can see thinning of posterior horn of lateral meniscus was noted, along with grade 2 signals and mild extrusion of its body beyond the tibial margins. In the first image, you can see that. Then partial tear of medial collateral ligament near its femoral attachment site was noted. Patchy PDFS hyperintense signal in medial condyle of femur and posterior aspect of lateral condyle of tibia were noted, which were suggestive of contusions. Edema was noted in Hoffa's fat pack and moderate joint effusion was also noted. This was the case 3. Here, high-grade partial tear was noted of ACL with the disruption of fibers near tibial attachment site. Then we could also see sprain in the PCL. Then we could see anterior translation of tibia measuring approximately 9 mm with uncovering of posterior horn of lateral meniscus. And grade 3 tear in posterior horn of medial meniscus involving inferior surface was also seen. This was case fourth. Here we could see complete tear of ACL at its mid-third segment. We could also find complex tear in posterior horn of medial meniscus and sprain along the PCL. Mild joint effusion was also noted. This was case 5. Here we could see displaced vertical tear of anterior horn of medial meniscus, and we could see complete tear of ACL at its mid-third segment. We could see sprain in the PCL at femoral attachment site, grade 2 signals in body in anterior horn of lateral meniscus, and vertical tear in the body of medial meniscus. Mild joint effusion was also seen. In case 6, we could see subchondral cystic areas in intercondylar region of tibia near the anterior cruciate ligament, which were likely intraosseous ganglion cyst. Extrusion of medial meniscus with grade 3 tear in posterior horn and body region was noted. Then full thickness cartilage loss was noted at medial facet of patella with subchondral reactive changes suggestive of chondromalacia patella. Edematous signals were also noted surrounding the popliteus tendon in near musculotendinous junction, and subchondral edematous signals are also noted in medial femoral and tibial condyle. So, uh, in the overall 30 patients, we could see PCL injuries were seen in mostly 14 patients. Then ACL injury was seen in mostly 23-24 patients. The most common finding here was joint effusion, and the second most common finding was bone fracture and contusions. In the ligamentous injuries, we could find the most common injury was ACL injury, followed by meniscal injury, then collateral ligament injury, then patellar retinaculum, and then PCL injuries. ACL injury types, we could find that complete ACL tear was most common, seen in 46.7% of people among the 30 patients, and then followed by partial ACL tear, then avulsion fracture, and then interstitial fibers. Then PCL injury distribution, the most common finding was sprain. Partial tear was second most common. Then complete tear and avulsion fractures were seen. In medial meniscus, grade 3 injuries were most common, followed by grade 1 and then grade 2. Lateral meniscus injury grade distribution, grade 3 was most common, followed by grade 2, then grade 1. LCL versus MCL, MCL injuries were more common. Conclusion was that advantages of MRI are that it is non-invasive, excellent soft tissue contrast, multiplanar imaging capability, and early detection, etc. And it is a modality for comprehensive evaluation of trauma, knee joint trauma. So MRI provides detailed visualization of ACL, PCL, and other ligaments and delineate the soft tissue structures with high resolution and directly impact the treatment planning by identifying severities and extent. These were the my references. Thank you.